Morning, everybody. Just a 2-minute warning here. Oh, you were all wondering then, weren't you, whether you should be on guard. 2 minutes. Okay, ready? Okay, good morning, everybody. Lovely to see you all. Welcome to Endeavour House. And what month is it now? The July meeting of the Suffolk North East Essex Integrated Care Board. It's lovely to see you all. First of all, just a reminder to us all that we are live streaming, so we're going out live to members of the public today. Rules for meetings, so it's actually a while since we've met. We've got quite a tough agenda to get through in a relatively short period of time, so we'll have to go at pace. But before I do that, to kick us off, we've got some people here today who are in their last meeting, and some people today who are in their first meeting as well. So first of all, Georgia, I think this is going to be your last meeting, isn't it? So, Georgia, thank you for everything that you've done for the Integrated Care Board, and the best of luck with your new future. And Paul, is it also likely to be your last meeting? So thanks to you as well, and good luck with your new future too. First meeting, I think Elaine and Chris, your first public meeting, not your first board meeting, but your first public meeting. So welcome to both of you since your appointment as NEMS. I think Dave Cargill as well. Dave, your first meeting since being appointed what seems a long time ago, so welcome. And I know, Sharon, you've been before, but you're deputising today for Susanna, aren't you? And Councillor Wiles, Steve Wiles at the back there. Steve, the new co-chair of the Integrated Care Partnership, so welcome to your first meeting as well, Steve. Is there anybody else who I should have said welcome to, or are we all... We're all not first meeting.
Kath's deputising for Caroline.
Oh, Kath, yes, thank you. Yes, you're deputising, of course. Mind you, you've been before, haven't you? But deputising for Caroline. Yes, thank you, Ed. And that takes us on to apologies. So, Tom, I've got Frida Barty, Caroline Donovan, of course, with Kath here, Susanna Howard with Sharon, and Nick, I think you're going to have to pop out 10 till 11. 10 till 11, yeah. Yeah, no problem. And Maddie Baker Woods. Have I missed any, Tom? Or is that it? Okay. Questions from the public. I know we've got 3 in already from Mr. Dooley. Thank you for those, and we've slotted those through the agenda, and Simon and team members will deal with them appropriately. Are there any other questions from members of the public in before the closure date? No. In which case, we may then have some questions at the end of the meeting from members of the public, and we'll deal with those at the end of the meeting. So, declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item, other than those of which we're aware, of course? No hands raised, so none done, none declared. In which case, minutes of the previous meetings, there's 2 before you, public meeting, 19th of March and 26th of March. Let me see if we can take them on block for truth and accuracy first. So, 19th of March, any issues with regard to accuracy on that draft as received? Otherwise, are we content to approve as a true and accurate record of the meeting? Approved, thank you. And then 26th of March, the same. Any issues, Andrew?
I think I was delighted when I picked up a typo.
You picked up a typo? Oh, well done. What did you spot?
20.3 and 20.4 on page 19. No, page 19 of the pack. I think it should be Reynolds rather than Reynolds.
Ah, well, good spot. Leave that one with you, Tom.
Yeah, great.
Thank you. Any other issues? So, subject to typo correction, are we happy to approve as a true and accurate record? Approved. Thank you very much. That takes us on to matters arising and the review of outstanding actions. Now, bar 1, which I'm going to come to Richard for in a moment, I think the rest of the items are either closed or not yet due, but I'll ask the question whether you agree with that when we've gone to Richard for the update on out-of-area placements. Richard.
Thanks, Chair. So just to remind the board, there was an action from, I think, the previous performance report, the one before, just to understand a little bit more about the mental health out-of-area placement. So this is a target that each ICB has this financial year, indeed it had last year, which is to get down to no one being placed out of area effectively for an inpatient provision. So we've got a trajectory in place for both NSFT and ePut as our main 2 providers that gets us down to 0 by the end of this financial year in line with the national target. And we monitor that on a monthly basis through our quality control and performance meetings with both trusts. At a highest level, NSFT are broadly on track. Indeed, they've got the 2nd lowest out-of-area placements in the region, and ePut are slightly behind trajectory, but for North East Essex specifically, again, it's one of the lowest in the region. We also monitor it through our mental health collaborative that we've got for Suffolk and the North East Essex Mental Health Group. If the board wanted to have a particular focus on this, I would suggest that we pick it up through SOAC, which is the performance committee. But at this stage, the point in time in the financial year, I'm not concerned about it, but it's one we need to keep an eye on. Thank you.
Richard, thank you. So Richard's update there and the suggestion that we refer any concerns back through SOAC. Everybody content with that? Any questions specifically for Richard? Thank you for that, Richard. So with that, and my comment earlier that the other matters arising were either not due or complete, is everybody content with the record as presented and happy to endorse the actions as undertaken? Everybody happy? And are you also content that the matters arising log represented a true and fair record of the matters arising due? I'll come to you, Mr. Dooley. So board content. Yes, Mr. Dooley, do come in.
Statement in relation to 9 to the 26th March meeting. I don't regard the statement from Ed Garrett to my question as a sensible and
You've just got a microphone coming, Mr. Dooley. Yeah, there you go.
Okay.
Yep.
It's in relation to 9-2 and the 26th of March meeting. I don't regard the statement from Ed Garrett to my question as being intelligent, reasonable and accurate. Thank you.
Okay, so what we'll do is we'll take an action to review that statement and, if necessary, amend and update. So thank you for that. We'll review that. Everybody content? All done? Good. In which case, shall we go on to item 6, which is the CEO's update? So Ed, I'm coming to you for that.
Thank you, Chair. It's been government coming in have made some strong statements around performance and regulation from the CQC. They are tackling the financial inheritance that they've got, and we will be watching very closely for the implications of that around the new hospital programme. And they will be launching the production of a 10-year plan, which I think will be starting this month through to next spring. So we hope to contribute to that plan. They've also sent a strong signal around investment in primary care and neighbourhood working, which is something that we would welcome, certainly here in SNE. The BMA have closed their ballot for collective action in general practice yesterday. That, I think, we'll wait to see the result of that, but we're preparing for actions to take place from Thursday, I believe. Particular ambition around limiting appointments in general practice as part of the collective action, which we are planning around because that will have a significant impact in the operation of the system as a whole, as well as other changes and initiatives that might be brought forward. So that's very much at the forefront, I think, of all of our minds at the moment. There was, as we know, a global IT outage in recent weeks. I think the system responded well from an emergency planning perspective. We had a number of GP practices affected. There were EMIS practices who were unable to review their clinical records for a time, but we kept the show on the road and recovered well. So thank you for everyone's contribution to that. In terms of some notable issues I wanted to raise, firstly, there's been quite significant national media coverage of the Cedar Signs cancer work that's been led by Dr. Pete Holloway, who's a GP in SNE. That's using artificial intelligence in general practice to improve detection rates, and we've seen a 12% improvement in cancer detection rates in SNE, where we've used that intelligence. And we've particularly got now 82% coverage in Ipswich and East Suffolk Alliance using the tool, which is, I think, really great for the patients involved. We've procured and launched a new NHS talking therapy service with NSFT in the voluntary sector in Suffolk, which we're really excited about. There's been investment in a mental health hub in Clacton, which is run by the Citizens Advice Bureau there, and offers a great model of integrated care. And we'll hear later about all of the engagement work around the elective orthopedic centre that's been underway, and we'll receive the report from Health Watch and others later. Finally, I just wanted to pay tribute to two outgoing Vice-Chancellors. So Helen Langton at the University of Suffolk has retired, as has Anthony Forster at the University of Essex, and both have been tremendous partners to us and have really prioritised health as a key strategic aspect of their universities. So we wish them both well. Thank you, Chair.
Ed, thank you very much. And yes, perhaps I could reiterate the thanks to everybody for battling through in the face of change at the moment. But 'twas ever thus, wasn't it? And thanks particularly, I think, to Helen Langton and Anthony Forster as well. So good luck in their new futures, shall we say. Any questions for Ed and Elaine? Yeah.
If I may just raise a question. So I appreciate the government announcement.
Elaine, if you just turn your...
Hello.
I appreciate you mentioned the government announcement regarding budgets, and I know this is very early days, but I did wonder if you could perhaps set any expectation that we might expect an impact, particularly on things like the new hospital programmes. If it's possible to give it any indication would be helpful.
Okay.
I think it's too early to say, Elaine, that they're obviously prioritising pay commitments, and we've kind of read about that this morning. But with the big capital investments, that's something that's under review. I think we need to respond really quickly once we know a bit more. Clearly, there's a financial challenge they've inherited, and they're going to have to make some difficult decisions.
Thank you.
Thank you, Elaine, for that comment. And Ed, your question as of this morning, following the Chancellor's announcements yesterday, very appropriate. But I think also I suspect the board would want an NHP update on the September agenda, and then given that the budget is on the 30th of October, it's highly likely that our November board should also get a further NHP update. So should we schedule that? And Tom, can we leave that to you? Okay, thank you very much. Any other questions or points to raise? All done, so noted. Thank you very much, Ed. In which case, shall we go on to item 7, which is the dental commissioning plan progress update. And Peter, I'm going to come to you and colleagues.
Great. Thank you, Chair. The board remember 4 months ago, Nick Barker and I presented our dental plan with a broad-ranging set of actions and a programme of work to recover our position with regards to oral health across Suffolk and North East Essex. And we committed to come back every 4 months to give you the headlines of how we're getting on. And so I'm really pleased to welcome Nicola Brunning today, who's our Assistant Director leading the dental programme and pharmacy, optician and vaccination commissioning. And so the board has in front of you our update. I'm just going to hand to Nicola for some headlines of some of the things that we're really proud to have seen some progress with. Thank you.
Peter, thank you, and welcome, Nicola. Over to you.
Thank you, thank you. Did you want me to answer the question initially as part of the agenda, Simon?
Do you want to do your intro first, and then what I'll do, Nicola, if it's all right with you, I'll ask Simon to read out Mr. Dooley's question, then we'll come to you for the answer. Is that?
Yeah,
that's
okay. Fine, thank you.
Over to you.
Okay, so what I thought I'd do is draw out the key areas where good progress has been made over the last 4 months, and I started in post in April this year. So one of the key areas is prevention, and we're working alongside our local authorities to support a number of initiatives to enhance the number of prevention programmes in place across SNE, which are listed in the paper. Just to give you examples, things like we've expanded supervised toothbrushing in children in early years and infant schools. We've invested further in an initiative in a new service is going to be launching in Suffolk in September this year, which is a mobile assessment and treatment service, which is being led by Suffolk County Council and will focus predominantly on the most vulnerable populations within Suffolk. In Essex, again, a number of initiatives are underway, including young people have been trained in 15 schools to be oral health champions, which I think is really lovely, lots of young children. Encouraging their peers to adopt better oral health habits. And there's an initiative in care homes called Lifelong Smiles, where care homes are accredited to deliver oral health prevention. And so far, 8 homes have been accredited and more are signing up to the scheme. So that's just an example of a number of additional initiatives that have made some headway since April. And really importantly, actually, we're in a process of mapping and doing some due diligence in relation to prevention. So what do we currently have across SNE? And we don't have a brilliant picture of that currently. So we're working alongside health, education, care sector and voluntary sector to understand what we currently have, so our current assets in this area, which we'll then collate and analyse in August this year. And we'll then work with a wide group of colleagues from across our system to start the co-production of a strategy and plan in relation to prevention. So that they're the sort of key items relating to prevention. Workforce development, you would have heard in March some of the challenges that the dental workforce is facing. So I'm really pleased to say that we have established a workforce subgroup since the last meeting, which was facilitated by Amanda Lyes. And we had a brilliant meeting where we're just trying to understand what we have got now, where we want to get to, and how we're going to get there. And we're going to be in the early autumn arranging a workshop with a wide range of stakeholders from across SNE to inform the next steps, which will culminate in the production of a strategy and plan relating to workforce development. And then a couple of smaller initiatives, but just as important. We support GP practices at the moment with recruitment with an organisation called Primary Care Careers. We're testing that out with dental practices, and we have 15 dental practices involved in that initiative. And if it all goes well, which we think it will do, we'll probably commission that substantively to support wider workforce recruitment across the whole of the dental workforce. And then you'll see in the paper there's reference to the University of Suffolk and the University of Essex and the undergraduate courses that they're offering there, which are expanding over this year. So there's just some real progress being made with the support of both of our universities. And moving on to priority groups, which was another key area. The main initiative that has and progress made since April is an initiative called DPAS. It stands for Dental Priority Access and Stabilisation Service. In a nutshell, it's an 18-month pilot which launched in April this year. And it enables dental providers to provide sessions for our most vulnerable groups within our population. Those vulnerable groups are listed on page 3 of the report under 4.2, but for example include children in care, care leavers, people with dementia, and people requiring urgent and emergency care. The pilot launched in April, and so far 18 providers are participating in it, and with a couple more due to come on board shortly. The dental practices receive referrals through a number of routes, mainly through signposting, predominantly at the moment through NHS 111, but we're working with organisations like the hospitals and NSFT to support referrals for the other patient groups. I'm pleased to advise you that since the scheme started in April, over 2,000 people have been offered an appointment. The majority of those are under 60 years old, and at the moment, the majority of those are people who are requiring urgent emergency care. And there are lower referrals from high-risk groups, but the team that I work with are working really hard with partner organisations to support those groups to increase through the pilot. Evaluation criteria has already been agreed and is being monitored. Progress is being monitored. The patient feedback that we've had so far has been overwhelmingly positive, particularly with the fast access to care for those who are in a lot of pain. The 18-month pilot will be evaluated, and we're hoping by Cambridge University and working in partnership with colleagues from King's College London. But fantastic progress has been made, and we're anticipating around 8,000 appointments will be delivered through this scheme over the next year and a half. And the evaluation, of course, will inform the future commissioning approach. So what have we been doing to increase access for the rest of the population? Unfortunately, we measured in units of dental activity, and we have a target to restore the levels of UDAs delivered to pre-pandemic levels. And so we set out in the last paper a 3-year trajectory to achieve that. So last year, so 23-24, activity was 3% higher than the year before. And Q1 for this year, 24-25, is 10% higher than it was in 23-24. A number of actions have been taken to support the increase of UDAs provided. For example, commissioning more activity. The University of Suffolk, as a provider, has now opened. And then we're supported by some national initiatives, such as the new patient premium, where dentists are remunerated to bring additional new patients into their services. So it's a number of factors which influence the number of UDAs delivered. The next most important focus for the team is to explore areas where in Suffolk and North East Essex there is no dental provision. So we don't have equitable access to primary dental services across SNE, and there are areas within SNE that have no access currently. So we're drawing together the insights to help us understand, as an ICB and as commissioners, working alongside stakeholders, where those gaps are and what the approach should be in terms of perhaps potentially procuring services in various geographies across the area. Another challenge the team has faced is, and it's taken up quite a lot of activity, is that one dental provider has served notice on 2 orthodontic contracts, which has meant one was in Clacton-on-Sea and one was in Bury St Edmunds. And this has meant 1,700 children who are either in treatment or on the waiting list we have to find them a new provider. So we have successfully identified
I just wanted to also just thank Amanda Lyes for the work on the workforce side, and also David Cargill has joined us as our chair of our Dental Commissioning Committee, where we're making our decisions on this programme. Thank you.
Wonderful, thank you very much. In which case, before I open it up for questions from the board, and I noted you, Elaine, Simon, would you like to read out Mr. Dooley's question, then Nicola will come back to you for the answer.
Sure, so the question is, I would like an explanation. Are we switched on? Testing.
You're on now.
We are on, okay. So the question is from Anthony Dooley. I would like an explanation as to why there was no public and patient engagement with regards to the Dental Commissioning Report.
Thank you for the question. In March, the ICB board endorsed the dental strategy and draft plan, which was developed through engagement with a wide range of public and patient representative bodies, such as Healthwatch Suffolk and Healthwatch Essex, who shared their insights relating to dentistry at that meeting and are supporting project evaluation. Patient satisfaction is referenced in the report. For example, the evaluation criteria of the DPAS pilot includes patient feedback, which is being systematically collated and reviewed, and favourable so far. And finally, meetings have been held with the Suffolk Health Scrutiny Committee and Essex Health Overview and Policy Committee, most recently in July 24. These meetings are an opportunity for detailed questions and challenges to be made in respect of NHS dental services and to review progress made. Further details can be shared on patient experience in future reports if the board wishes to see this. Thank you.
Okay, thank you very much. So I've got 3 questions at the moment. I'm going to go to 4 now. Right, I'll start with Ed and then Elaine, Fanwell and Kath. So Ed?
It's not so much a question, just drawing the board's attention to 4.2 in the list there. So, you know, as a board, as a system, we prioritise health inequalities, and the DPAS scheme is nationally different. We've been very brave taking that step, and really pleased to see Mid and South Essex following, and I'd hope other ICBs might follow through, but that was a courageous decision to make given the context we're working in, but absolutely the right thing to do, and the feedback we're getting from that cohort is really positive. So, you know, really well done.
Yeah, thank you. Good to flag the inequality, the importance of addressing inequalities to us. Thank you. Elaine.
Thank you, Chair. So, Nicola, thanks for the update, and really good to hear so many positive things being done to address this. I noticed you talked about one of the metrics being the units of activity delivered. My question was really to try and understand, in terms of the people that need dentistry help, how many of those are actually getting it. So I just wondered if you have got a metric that's around the need of the population and the amount of that that's delivered. So how many people need dentistry support and how many actually get it?
We don't currently have a metric in terms of tracking against need of the population.
I mean, the two indicators, I guess, as proxies that we look to is that we look at the percentage of people, adults and children, who've accessed an NHS dentist in the last 24 months. So that gives us a sense of the number of people accessing the service. Because one of the dangers of the units of dental activity model is you could see one person 4 times for a health check in 2 years, or you could see 4 people once, and those are two very different types of service. So the number of people is a proxy, and then the region have a public health service, and we have a consultant public health who works for us and North West Anglia, the Norfolk and Waveney and Mid and South Essex. They give us an annual report on specific aspects of dental need, and so they give us different reports, and so we have but they're quite focused. But I think it is something we need to work on over time to get those reports really clear and meeting the needs for us. So I think if that helps give that we have some proxies, but it is they're judgments at the end of the day.
Okay, thank you.
Thank you, Elaine. Thank you, Peter. Fanuel?
Thank you, Chair, and thanks, Nicola, for the presentation. A couple of things I wanted to note. I think the first point, Ed mentioned the cohort and the priority groups that we're targeting. I think it's an important thing. I suppose my comment on that is because we're limiting the comms for fear of the service being overwhelmed. I think it's important that we careful not to then miss out on some of the most vulnerable because they are not aware of the existence of the service. The second point I wanted to make is around the training. I think it's also a great thing that we're now training those students here. Are we doing anything specific to ensure retention of some of those in SNE upon completion of their training programs? Thank you.
Thanks, Fanuel. Shall I come back to you, Nicola, for answers to those 2 questions?
Yeah, thank you. In terms of the capacity for DPAS, we completely recognise that we need to use 100% of the capacity, and actually some dental providers have now reached 100% of their capacity. It is being tracked as part of the ongoing review of the scheme, and the team is working with particular cohorts of clinicians to support in more signposting into the service. So, for example, working very actively with colleagues at West Suffolk Trust and ESNEF's Trust to ensure that people who are undergoing cancer treatment or who arrive in the emergency departments, for example, can be referred through this service. So we're taking it, we're going as fast as we can in as measured a way as possible, bringing alongside stakeholders such as other organisations to support signposting into this pilot. In terms of retention, I think perhaps Amanda might be able to pick that up.
Go on, Amanda.
Thank you very much, Nicola. So thank you for your question, Fanuel. So the retention is some of the emerging piece of work that Nicola and Peter alluded to, which is what I'm leading in the autumn. But I do know that Essex University are looking to consider a research and development project which will focus on the retention of students so that they have greater exposure to wider dental procedures and the like. And they're talking about potentially spreading that into social care to really enrich and enable to have proper portfolio careers going forward. So we're in the early stages, but we're working up proposals to focus on that retention because we spend a lot investing in students. We want to keep them within our system and for them not to go further afield.
Yeah, thanks, Amanda. So work in progress, Fanuel, I think, on that.
How people are being signposted, there doesn't appear to be anything obvious relating to those people with learning disabilities or autistic people and with the communication challenges that they have. So I wanted to make that point.
Yeah, thank you for making the point. So my colleague Becky has been working closely with NSFT and EPUT, and colleagues from those organisations have actually developed some really lovely posters and co-produced them so that the information within them is accessible to everybody, and they're in the process of being rolled out across SNE, so really positive. Thank you.
Yeah, good flag, Kath. Thank you. Andrew?
I just wanted to come back on Elaine's question about dental needs and dental demand and suggest this might be something we could bring back through the Quality Committee as part of our overall look at dental quality. It's got relationships to that area, hasn't it? So we can undertake to do it there.
Okay. Should we take that as a board request? Yeah? Okay. Lovely. Any further questions? Otherwise, shall we say, Peter, Nicola, thank you very much. Progress report, really useful, well received. I think in summary, you're indicating good progress, shall we say, so far, but also lots to do. So would I be right that the next scheduled update for the board would be in November? Is that right? Yeah. So go on, Peter.
Yeah, no, absolutely right. And the other thing I should just flag is we're keeping an eye on the new government's policy announcements as well with regards to 700,000 extra appointments and what that exactly means. So I think, and hopefully, as relates to one of the previous questions, we'll be in a position to perhaps understand that a bit further, but we'll definitely have the update in November. Thank you.
Okay, lovely, thank you. So next update, November. Everybody content? Noted? Lovely, thank you very much. Let's then move on to item 8, the Elective Orthopedic Centre. Now, Amanda, I think I'm coming to you to do the intro, then you're going to hand over to Simon and Luke, combination of colleagues. I'm not sure, Andy, whether you're leaving it to colleagues. Lovely, thank you very much. In which case, I'll let you kick off, Amanda.
Sure, thank you very much, Chair. So by way of introduction, I would like to inform the board that obviously we were made aware, in March it was actually, through Mr Andrew Dunn, Orthopedic Surgeon and Director of ESIOG, and Simon Morgan, our Associate Director of Comms. They both gave an overview of a proposal to actually move 55% of elective orthopedic activity from West Suffolk Hospital to Colchester, and a proposed approach to engaging local people across West Suffolk was articulated to the board. The board, as a result of that presentation, approved the engagement approach, which was led by the ICB and Simon's team, with strong support from Suffolk Health Watch and indeed West Suffolk Foundation Trust. The engagement exercise started and concluded at the end of June, the 30th of June, and this report gives the board an overview of the findings which Luke will present in a moment. This will involve, the board is asked to note the findings which Luke and team will present and to approve the engagement undertaken to date, which will allow the next stages of the process to progress. This will involve developing plans to address key issues of concern, notably transport, and if the board agrees, to start the process of relocating appropriate services that were subject to the engagement of the new centre. Health and Overview Scrutiny Committee have requested that they are updated at its next meeting in October in terms of how we will address the recommendations identified from the engagement exercise. And I think, Chair, at this point, I'm now going to hand over to Simon and team to bring the findings to life. Thank you.
Thanks very much indeed, Amanda. We have got some slides which hopefully will appear very shortly. But I just wanted to introduce again to you Andrew Dunn, the orthopedic surgeon and also director of the new ESIOG Centre in Colchester, and also Luke Bacon from Health Watch Suffolk. Luke will be going through some more slides a little bit later on. The lion's share of the slides, I think it's fair to say, in a second or so. So I don't know where the slides are, but I'll go through. Next slide, please. The engagement started, as Amanda just said, on the 20th of May. It ran for a period of 6 weeks in total. There we go. And it was primarily to understand people's views on the impact that the proposal would have on local people across West Suffolk and beyond as well. The communications approach that we took for this was very much hand in glove. We were working very closely with our PPGs, the Trust, and also Health Watch as well. We produced a toolkit for patient groups and stakeholders to help increase awareness and also to amplify our messaging as well. We attended many locality meetings across West Suffolk and also held about 8 or 9 mini exhibitions in various locations in towns primarily across the district as well. We had pop-up stands in supermarkets and libraries in areas of high footfall, and the Trust did a really detailed equality impact analysis and travel assessment, which was produced by our colleague Cassia Nice. It was a really good piece of work, that. We had advertorials that were featured in local newspapers, primarily in the Bury Free Press titles, which included the Haverhill Echo, Suffolk Free Press and other titles in West Suffolk. And we held 2 virtual events, one on a Wednesday evening, the 5th of June, and a Saturday morning on the 15th of June, just to make sure that those perhaps who couldn't attend any of the above mentioned events could at least dial in or attend a virtual event as well. We produced leaflets, banners, website materials and various briefings. Andrew also very kindly held a virtual tour of the new centre as well, all of which were available at the exhibitions and online. And we produced our materials in a range of different formats, including easy read, translation and also audio formats as well. Next slide, please. A quick word on how we gathered responses. So we wanted to ensure that an independent approach was taken. It was no good the NHS marking its own homework. So we wanted to work closely with Healthwatch Suffolk. And they came on board to oversee the gathering of responses, to ensure that independent approach was taken, and also to analyse the findings and draw out key trends, and then to produce a report which they've kindly done for the ICB board to consider, which Luke's going to go through in a second. We had over 2,000 responses, 2,218 to be precise, between the 6 weeks of the engagement. We also received several postal responses as well, and the co-production of the survey was a really important part of our work, which took place back in April and early May as well. So with that, I'm going to hand over to Luke. Thank you.
Thank you, Simon, and good morning, everyone. It's really great to be here. My name's Luke Bacon. I'm a Research and Business Development Officer at Healthwatch Suffolk. And yeah, as Simon said, here to talk to you about our independent analysis of the survey data gathered by the ICB about people's opinions on the ESCOC. Were from people already waiting for orthopedic care from West Suffolk Hospital Foundation Trust, and 5% were carers of someone waiting for elective care. A small proportion were waiting for care from either ESNEFT or another provider. If we look at the overall sentiment, then almost half of respondents, or 48%, were positive about the proposal overall. There was 35% who were negative and 17% who were mixed, so just as a rough guide to what people thought. Overall levels of sentiment do vary in the survey depending on who we're talking about, who's responding. So, for example, 75% of people who were waiting for elective care were positive about the proposal compared to 58% of members of the public. And we found that quite consistently, that people who were waiting for elective care were more likely to be positive about the proposal, we think due to the impact of quality of life on waiting and wanting to have that surgery done. On the other hand, people who reported having additional support needs, such as a disability, mental health difficulty or long-term health condition, were less likely to be positive than those who reported no additional support needs. The survey also gathered the first part of respondents' postcode, and the map on screen shows the percentage of respondents who were negative about the proposal within each postcode district. I think the trends in the area data can be quite difficult to interpret. If it's something that you're interested in, then I'd really recommend going and having a look at the report. Most of the questions are broken down by postcode area there. However, very generally, people in areas such as Bury St Edmunds, Mildenhall, Haverhill, Brandon, and South Norfolk areas such as Feltwell were more likely to be negative about the proposal. And people in areas such as Sudbury, Ixworth, Elmswell, Stowmarket, Thetford, Eye and Hadley were more likely to be positive. It is positive to see that the majority of people felt that they would be able to ask for a lift from their family or friends if they had a procedure scheduled at ESCOC. However, 20% who responded to the survey said that they didn't know how they would travel there. Like the overall levels of positivity, people who were already waiting for elective care were more likely to say that they would be able to get a lift, so possibly indicating that they already have those plans in place. Similarly, most respondents said that waiting times were a priority when choosing their provider over the distance from their home, as shown on the slide. Although, again, people who are waiting for elective care were more likely to say that waiting times were the most important factor for them. Finally, there were hundreds of people who told us that they were worried about factors such as travelling in the dark during winter or being away from their support networks when attending an operation in Colchester. So I feel our role in this as an independent health watch really is just to reflect what people have told us in the feedback. So our recommendations really are to highlight key priorities from what people have told us, particularly in their free text responses. There's a huge amount of free text data that we've analysed, going into lots of detail about what people thought were the concerns for them. So the top priority we'd recommend that the board consider is transport. The cost of transport, rurality, public health links, and particularly also social isolation can make travel to ESIOC really difficult or impossible for some patients without some kind of support. The board could consider what transport options are available and ensure that people have the information they need about how they can get help if they are eligible. The board could also consider the access policies of the ESIOC and West Suffolk Hospital Foundation Trust. So this includes what the criteria are for patients who may not be able to travel to ESIOC to choose to have their procedure at West Suffolk Hospital. People also need to be informed at the point of referral about what their options are, what it means if they opt to have their surgery at West Suffolk Hospital, and realistic information about wait times and risk of cancellation. People had lots of questions about what moving their procedure to the ESCOC would mean. So people wanted information particularly about parking availability and charges, what facilities were available at ESCOC, and where their pre- and post-op care would be based if their procedure was in Colchester. So sharing clear information about these could help people to feel more confident about having a procedure planned there. Being able to visit family members was a key concern that was repeated throughout the survey. Some people felt that the distance to travel for them to visit was a particular barrier. This can be really crucial for family carers if the person who they care for requires continued support or help with communication. In those cases, the SCOC may require facilities for people to be able to stay or information about how family members and carers can stay nearby. Finally, the survey heard from large numbers of people who were vulnerable or had additional support needs. It's critical to ensure that the ESCOC can meet people's needs, for example, ensuring that the centre is dementia friendly. It's also critical to ensure that people have information about their choices and what they can expect if they receive care at ESCOC in multiple formats and in their chosen language. I'd round off by saying I think a special thanks and congratulations should go to the comms team and Simon, who worked on this project, for the number of responses they were able to gather in that short window. I think the response actually reflects really well on the ICB and West Suffolk Hospital's commitment to listen to patients and the public. I really hope that the board's able to take forward some of those recommendations and actions, and I know that people will really welcome being communicated with about what some of the outcomes from their feedback have been. So thanks for your time, and I'll hand back to Simon for next steps.
Thank you very much indeed, Luke. I'll pass over to Andrew in just a second, just to see whether there's anything Andrew would like to add in terms of his reflections. But in terms of next steps, there's a variety of them that we will consider going forward. One is that we will be feeding back to communities on how their views and how the feedback that Luke just described will be used. So you said we did. There'll be further communications and marketing about the new ESIOC Centre facility, where we'll be working closely with ESNEFT and also the centre itself and the trust. Senior level discussions to determine a solution for transportation if the proposal is accepted today. We'll
Yeah, good morning, everyone, and thank you for asking me to join. No, it was a privilege to be involved in the engagement exercise. I think it's really important to engage with members of the community and listen to their views, but also it was an opportunity to I suppose improve and make patients more aware of the benefits of elective hubs and what they can offer. We know that the previous government put 1.6 billion pounds towards funding hub sites. There are over 100 up and running already, and there'll be 133 open by March, next year. And they're very much a key part of the national team's strategy to reduce waiting times for patients requiring elective surgery. And I think, as Luke highlighted in his report, the impression was that localities that we visited, obviously closer to Essex, patients were generally, very sort of, positive about it. Clearly in South Norfolk and in Brandon and in Newmarket, some areas further away from Essex, there were more, concerns, raised. And I think my conversations with patients in outpatients that I see clinically reflects that patients who are on waiting lists for treatment are generally far more positive about elective, hubs than patients that aren't currently waiting for treatment. So I'll stop there. Thank you.
Okay, Andrew, thank you very much, Luke. What I suggest we do, Simon, we've got a question from Mr. Dooley. Would you like to read that out, and then we'll get an answer from yourself, probably, and then we'll go for open questions.
Okay, thank you very much indeed. So the question from Anthony Dooley. I would like to know how the SEOC provision was funded and whether it will be a wholly public provided service with no associates appointed. And perhaps Andrew, I could ask to respond to that. Thank you.
Yes, the funding came from the government part of the 1.6 billion pounds that was that was provided for the building of elective hubs across the country.
Okay. So, open for questions. So I've got Kath, Owen, Elaine now as well. Nick, should I go to you first, and perhaps you, and if you have anything to follow up on, then I'll go round the table. Over to you, Nick.
Thank you, Chair, and thank you for the report. Just to confirm that obviously those issues around access that were mentioned there have been part of our planning for 7 years. So it is absolutely embedded within all of the planning. And I think the feedback that we had is not dissimilar from some of the work that we did as part of the consultation, which was formal consultation when we about 2 or 3 years ago now. So there is a consistency there. So absolutely need to take that on board, understand what the actual numbers are, which actually, when you break it down, are relatively low. We've known that all along, but clearly important for those individuals. I think the issue around overnight accommodation and everything else, I mean, the length of stay is likely to be very short by the nature of the work. The patients that we'll be treating, but absolutely will, as ever, make sure that relatives and carers particularly are welcomed and supported in their care. Thank you.
Thank you, Nick. Ewan?
Yeah, I guess just to add that whilst we're clearly focusing on orthopedic patients here, the additional benefit of this proposal is that patients with other surgical problems on waiting lists in West Suffolk will get treatment more rapidly in the backfilled space. So whilst rightly the focus here is on the orthopedic patients, there are additional benefits to the population.
Yeah, underlying additional positives. Yeah. Good point. Let me then go to Kath next.
Thank you. I was just wondering, in terms of the engagement that took place, and I know 80% were over 55 of the respondents, but how does that compare to the actual proportion, the age profile of the people who would be using the centre? So I think it's important to think about the balance as well with regard to the there's only 20% of respondents that fall into potentially a higher proportion of users of the orthopedic centre, and they might be different considerations for us to think about. And then the other comment I was just going to make is more not so much about the engagement, but it might help respond to the engagement, is about whether or not there's some environmental adaptations that have been built into the centre for people, like low stimulus environments for people with autism, learning disabilities, severe mental health, and whether that might help counter some of the anxieties about the geographical area if we're able to then provide a more adjusted environment for them.
Okay, now I'm not sure whether we'll be able to answer all those questions now. Do you have any comments? Should we take those thoughts away, Nick?
Thanks, Chair. I mean, I know that the building has been designed with the most modern building standards and regulations, a much higher proportion, for example, of single-room accommodation, and therefore, but it's often about the training of the staff, isn't it? As much as it is about the environment, and getting that balance between having to provide a fairly using the word usage, but sterile clinical environment versus some of what you talk about. So I think, I mean, I'm sure Andrew can talk about the demographics. I think it pretty much reflects the demographic that we'll be seeing through SEOC. I think that's about right, isn't it? I mean, it tends to be an older population for the vast majority of the elective orthopedic work.
No, absolutely right, Nick.
Just pop your mic on there, Andrew. Yeah.
Apologies. No, you're absolutely right, Nick. I think when we look at the largest number of patients waiting for elective orthopedic surgery, they're patients waiting for hip and knee replacement surgery. That's the biggest volume of work that we have, and the large majority of those are going to be older, adult, patients, and of course those services are the most challenged because they need elective inpatient beds, as Nick's highlighted. Teams on all three sites have been working really, really hard to reduce the length of stay for patients having hip and knee replacement surgery. So it's interesting when we were talking to some members of the community, and they were saying, well, then a lot of Nick's team, Rossa Baker, very experienced matron at SNF, chaired the kind of patient group, and there was a lot of input from patients into the design of the building. So that was all taken into account.
Okay, thank you. Elaine?
Yeah, it's really good to see the level of engagement, and Cass' point, I know about, was it fully representative of all the people that are likely to use it? Bearing that in mind, there are some very specific recommendations coming out of the report, which was good to see. So my question really was about timescales. I am assuming some of these recommendations will be picked up. If the intention is that that would be done before the centre opens, because I'm mindful that's just a few months away, if that is the intention. So really just a question on timescales for implementing recommendations.
Sorry, just before you comment on that, Elaine, I'm thinking that the board would probably want feedback on the progress on the recommendations. It's in September prior to opening. Does that make sense? Is everybody supportive of that? Go on, Andrew. Oh, Peter.
Yes, so I think that's absolutely right. So there's really clear messages, particularly relating to transport here, aren't there? There's some about the environment, but mostly relates to transport. And so I think we need to commit to come back to the board in September with the outcome. And I think just listening to Nick's comments, I wonder if we should be, whilst this gives a really clear picture on the West Suffolk issues, I wonder if we should be giving an ICB-wide total transport picture with regards, because there'll be some things that's already agreed or planned for the other residents in Ipswich and other areas that will have travel questions raised. So I think if we bring the two together to get a total SNE transport story, and so that we're ready for the October opening. There are some national provisions already made with regards to financial hardship and clinical requirements that we have. So I guess the question really is what else do we need to do to supplement that or not? And I think that's the sort of exam question we're taking away to work on in advance of October to reach a decision. Thank you.
Okay. So feedback in September, whether the priority probably should be the transport around ESOC, I imagine, and then it may well be that the wider transport picture has to follow, I would imagine.
Sorry, just to clarify, I'm talking about transport relating to ECOC, but what I heard Nick was saying was that there are already considerations and agreements made with regards to transport for people outside of Colchester for the other part of SME. So I'm just thinking, let's take the total story, so we're giving a clear solution for all SME residents with regards to SEO.
But orthopedic centre focused? Yes. Yeah, okay, got it. Do you want to respond to that, Nick?
Yes, if I may. I think there's just something about proportionality here. So when we look at the absolute numbers, I mean, a very back of the envelope, and I'm not the person who does numbers in the room, I'll leave that to clever people like Howard, but I think we're looking at about, if we work on a 40-week year of activity, I'd like it to be an awful lot more, but let's be pragmatic. At a 5-day week, it's 7 patients a day, of which 60% say they can find transport themselves. So I think when you break it down to the 2 or 3 patients a day, I think whilst I absolutely recognise for those 2 to 3 patients there, it's a really important issue. I think that we have addressed those, and part of the pre-assessment for all these patients, most of which will happen locally. So I think people have to remember it's only the operation itself that happens in the centre. The pre and post operative work and the rehab happens locally. And I think the issue about transport is an issue that has been around and will be around for any semi-rural area that we of the patients that we serve. So I think a wider discussion about access and transport is probably something that as a board we need to address at some point, particularly as it's likely there will be more movement of patients as we become more super specialist. It's always got to be a really important part. So I'm very happy to take that away, but I just think we kind of need a bit of a kind of check about absolutely recognise those 2 or 3 patients a day. It's essential, but just as a proportion of the number of people who are going to be seeing it. So I will come back, but just to say that we just need to manage our work a little bit. Yeah, if that's right, Chair. Thank you.
Okay. Content? Go on, Lynn.
If I may just come back, because the transport was obviously one part of it. There were other elements as well, so I guess I would like to think
the whole thing.
Yes, it's the whole thing that comes back as well.
Yeah, not just the transport, but on the whole...
all the recommendations.
On the parcel of recommendations, Okay, Janice and then Fanwell.
I think we're sharing one. A really comprehensive piece of work, so thank you for it. I think for me there's probably no surprises in the feedback there, but it's really important that we've engaged. These are issues that really are operational and need operational solutions, and it's in our gift to do that. So I think my plea would be the board needs assurance that these things are being resolved and managed with, and it's a personal conversation almost for the 7 patients, and the conversation about whether it's best to have that treatment at West Suffolk or at the new centre. And I think it's just assurance that there are mechanics in place for those individual conversations. Transport is an ongoing forever issue, and if we could crack it, that would be really good.
And that assurance we'll be looking to receive in September.
Absolutely.
Got it. Agreed. And then Fanwell.
Thank you, Chair. And I mean, reading through the report, and I think you have mentioned the equality impact assessment, which is a positive thing, although there's not much reference of it in the actual report. But my question is really around you mentioned in the report that on ethnicity, in terms of the responses, I think about 1.1% of the respondents were people identified with an ethnicity other than white or white British. I suppose, how do we ensure that we're not missing out on parts of our population in terms of the recommendations that we're making? Thank you.
Thank you very much indeed. So, as a communications exercise, we've had very good support from our local community groups. So we've had BME Suffolk, for instance. They were very, very proactive in terms of promoting the engagement with their members, and others have done the same. So for me, it's about working with those community groups asking them to spread the word within their networks, which they've done on this occasion, and to constantly work with them.
Thank you, Simon. Andrew, and then Ed, and then we'll try and move on. Andrew?
I just wanted to add in another balancing point on the, I mean, there's very real concerns raised by patients, as we've heard today. And Andrew has been very modest as he described the service, but one of the things we see with high volume, low complexity services is a real uplift in the quality of care provided and the quality of outcomes provided. To the outcome you receive.
Go on, Nick.
So, thank you for that. Really, really important. The other important thing to remember, for every week that SDOC is open, we take 2 weeks off the waiting list.
Yeah.
So just coming back to that constantly.
Yeah, so
there will
impact.
always be a trade-off
Yeah.
when we move capacity and we move delivery of care. But I think the trade-off in terms of reducing the extraordinarily long, the impact on people's lives is beneficial. Thank you.
Thank you, Andrew and Nick. Ed, over to you, and then we'll see if we can wrap.
Yeah, I mean, thanks again for the excellent leadership on this from Health Watch and Simon's team and colleagues in West Suffolk. I think the really important distinction I've heard is one you've made, Andrew. You know, in the general public in West Suffolk, 1 in 2 are positive about this, but of the public that are on the elective orthopedic waiting list, 4 out of 5 are positive. And that's the really important distinction, I think, in this debate, isn't it?
Okay, noted. So, colleagues, that was really useful, great presentations, colleagues. Thank you very much, and a really useful debate. First of all, huge thanks to Andrew and Luke. Andy, great Health Watch work. Thank you very much. Terrific report. And Simon, phenomenal amount of work there. And thank you for the team approach. I think the board really appreciate it. We're asked to, well, we do recognise that we must meet people's health needs, and that travel, of course, and all those associated issues are very, very important, as is our desire to address inequalities. So we're completely supportive of that if you like, that thought process. We're asked to support the next steps, which I think we do, but with a requirement that we get a report back to the September board. And is everybody in agreement with that conclusion? All done? Great. Thank you very much, everybody. Now, I'm very conscious that we are 10 minutes behind. So, despite having a tight time frame, we have slipped, but that was an important agenda item. I'm going to go over to Lisa now for item 9, the SEND inspection outcomes. Over to you, Lisa.
Thank you, Chair. I will just give a brief overview of the SEND inspection outcome, and then I will hand over to Richard to give an update on the progress that we've made in children's mental health and neurodiversity assessment. So I'm sure you are all aware that the national review that happened in 2022, one of the results of the review was the publication of a new area SEND inspection framework and handbook, which changed how inspections would be undertaken. And I've always been a real fan of the SEND inspection methodology. I think it's a forerunner of our CQC assessments for the ICS. It looks at outcomes for children and young people between 0 to 25. It does look at individual services, but it really looks at how does healthcare, education, further education work together, and communities to make sure that children and young people with SEND reach their impact and their potential that we should all come together to support. So everybody in the healthcare, education, voluntary sector, everyone has an absolute need to make sure that their services are meeting the needs of children and young people with SEND, and we all come together as part of the local area partnership. So in October, November 23, Suffolk was inspected under the new regime. You'll see in the paper that there were 3 potential outcomes, and I'm really sad to say for our children, young people and families that Suffolk received the 3rd outcome, which was that there are widespread and systemic failings leading to significant concerns about the experiences and outcomes of children and young people with SEND, which the local area partnership must address urgently. And as part of the inspection, we had feedback that there were 2 specific areas for priority action. So the first area is a very overview, kind of high-level narrative around governance, around the quality of multi-agency working, and about preparing our children the education, health and care planning process. We know for children and for families it's such a critical part of making sure that children get the support they need from all the services in a real integrated way, so that they start their education and their lives with the best that we can offer them. So they were the 2 priority action areas. There are 3 areas for improvement that we were asked to look at, which was around how we use performance data together. So not just looking at our own health, education and care data, but how do we come together to understand information effectively to inform sufficiency planning and joint commissioning of SEND services. Communication, again, is always something that we continue to work on, and again is an area for improvement that the inspectors found, and how leaders across the local area partnership should ensure that providers of services for children with social and emotional well-being, mental health and neurodiversity work together to meet the needs of children with SEND. So as a result of the inspection, we were required to draft a priority action plan, which we obviously did, which was submitted to the Department for Education and has been agreed with them. There is a very intensive monitoring process of the outcome of SEND inspections. We've already had our first deep dive by the DFE, which we're just working with the DFE on the draft report at the moment. And also as a partnership, we have revised the Suffolk SEND strategy because there are some real similarities. So we've updated the Suffolk SEND strategy. So there are 3 key areas of work for the ICB to very much focus on. One is our role as part of the local area partnership in that strategic partnership working and governance. You'll see in the paper we have revised our governance processes. We have our SEND Improvement Board, which now has an independent chair, which is excellent and will be a real benefit to us. And there are 2 other areas of work around improving waiting times and outcomes for children and young people with NDD and mental health. So I'll hand over to Richard, if that's okay, just to update you on those areas.
Thank you, Lisa. So as Lisa just alluded to, there's 2 areas of particular note for the ICB board, which neither of them I'd be surprised if anyone is surprised by, which is our current waiting times and support offer for children who are neurodiverse and related to children and adolescent mental health services. So just starting with the first of those, neurodevelopmental, 2.5 onwards, we've got significant waiting times, not out of line with, to be honest, the majority of England, and a renewed focus on what are we going to do in the short term and then the long term. Board members will be aware that we've previously brought an item which updated on nearly a £3 million investment that we've agreed to put into services to support waiting list reductions with all 3 of our local providers, so West Suffolk Foundation Trust, Norfolk and Suffolk Foundation Trust, and East Suffolk and North East Essex Foundation Trust, who are our 3 providers. So we've got plans with each of those, which also involves working with some external partners to start to bring down those waiting times by bringing in additional clinical capacity. And we've got an improvement trajectory from each of our 3 providers around how long it will take to start to work through those. In addition to that, I would say equally as important is, so what's the support offer to families while they wait for a potential diagnosis? I'm pleased that we are renewing our commissioning arrangements for the £1 million investment that the boards previously under the CCGs agreed to pre- and post-diagnostic support, which is predominantly from the voluntary care and social enterprise sector. We're currently in the process of co-producing the renewed offer, package offer, and then we're due to go out, subject to the board's agreement in September, around what that will look like. So I think that's equally an important area. Finally on that, we're also reviewing the overall model, because to be honest, it's not sustainable, even with the additional funding that we're putting in around some of the recovery of our waiting times. The demand upon our services for a diagnosis, potentially of autism and ADHD, is far outweighing the clinical capacity that we've got within Suffolk, and again, not out of line with the majority of the country. So we're re-looking at the model of care, and we're working, and I know Ed's part of this at a national level. There's a renewed national focus on what is the national plan related to neurodiversity, both adults and children's. And then the second area is CAMS, so adolescent and children's mental health. It's not a new area for us. It's an area that we've been working on collectively for a number of years. We're working with NSFT around the recovery of the waiting time, so our ambition is to get back within 18 weeks. I'm pleased to say that for CAMS, we're at 24 weeks, so it's starting to come down, and for YAMS, so as that's youth, we're at 10 weeks, so we're already below the ambition. More broadly than that, we've got a series of workshops that we've been running over the last few months with service users and with partners. It culminated in one about 2 weeks ago, where we had 60 different organisations and partners coming together to relook at our overall plan for children emotional well-being, and we're due to bring that model and that plan through our governance in September, and I would suggest, Chair, it might be an area that the board wants to look at later in the year. Thank you.
Thank you, Richard. And it sounds like we might be getting, we should be getting further updates, maybe September and November then, on that basis,
yes,
Richard.
Suggest so, yeah.
Yeah, okay. Let's note that as well, Tom, into the forward plan. Any other update, Lisa?
I guess just so the next steps for the SEND programme is that we will likely be re-inspected by June 2025. That will be our 18-month process.
Okay, thank you, Lisa. Elaine.
Thank you, and it's really good to hear all the work that's been done to address the findings around the systemic failing, particularly the priority areas, and really good to actually hear about that engagement with the voluntary sector. I guess my question was in terms of being confident that the issues are being addressed, rather than just obviously working through an action plan, how that's known. You mentioned the ongoing engagement with the DFE. It would just be good to understand how there's assurance that the actions are actually having the right impact, rather than waiting for the next report, which is obviously a long way away. So it'd just be helpful to understand how that assurance is happening along the way of implementation of those actions.
So I guess the overarching assurance happens through the SEND Improvement Board, which the DFE are part of. It's a very multi-stakeholder framework is very much about impact and outcomes across all of our services. So that's in development. The other area around accountability, so the second priority action was about timeliness of EHCPs. So the joint business intelligence teams have managed to develop a trajectory for EHCP recovery. So when we were inspected, our timeliness was at a very low percent. It was under 10% of meeting the standard that's required. We now have a very clear trajectory following the investment. Suffolk County Council have made significant investment into that service, and we track that through the accountability framework that we have.
Okay, thank you very much. So, Andrew, yes, last one.
It's just an offer of help, actually. So I just noted the 2.10 on page 5 of the paper. It talks about capacity consultant paediatricians. If any help with medical productivity and job planning would be useful, then please come to me.
Yeah, I think it would be. We had a meeting with Ewan's team last week, actually, and they raised a number of challenges around retirements, etc., that is going to impact on their wider community paediatric capacity. I'll take you up on that, Andrew.
Good offer, Andrew. Thank you. Let's leave that to you to take an action outside the meeting. Oh, sorry, Dave, yeah?
Sorry, just a really quick comment. Thank you for the report, Lisa and Rich. It's really interesting. And as a working GP, this really is a priority. It needs to be a priority of the board to get this sorted. And it's really, in addition to Andrew's comment about actually what could primary care, general practice support with your diagnosis and referral times, because I think there's an opportunity there for us to work collaboratively together to help with that.
Should we take that as an action outside the meeting? Richard, I see you nodding. Good offer, Dave. Thank you very much. So, colleagues, we're actually only asked to note, but I think we're receiving and noting the progress. Looking forward to further updates in September and November, and I suspect there may be others thereafter.
Finance pack is the 2024-25 financial plan and delegations to directors and committees, which has already been through formal board approvals in April and May. So I won't comment on those other than to say that the plan is compliant with our legal duties to spend within our resources and has also been approved by NHS England. So I'll focus on the papers detailing the latest financial position as at month 3. That's the period April to June. And firstly, a reminder to the board of the following. So when I use the word system in this context, really I'm talking about the formal ICS partners. So that's the ICB, E-East, Esneft and West Suffolk. The system has an overall balanced financial plan, which is in line with our £2.4 billion of funding allocations. And amongst the system partners, West Suffolk have an approved £15.2 million deficit plan, which is offset by surpluses from other partners, predominantly the ICB. The overall system is still presenting a balanced forecast for 2024-25. However, there are some areas of significant stress in the year-to-date position, which I will highlight by respective organisation. From the ICB, the position is balanced for both the year-to-date and forecast. However, we're seeing some significant cost growth, most notably in continuing healthcare, which we are currently predicting will overspend by over £4 million. That's driven by volumes and high-cost packages. As part of our mitigation plan for this, we have recently commissioned an independent diagnostic to review CHC processes, contracting, and how we commission those services. That work, I'm pleased to say, has started and is due to be completed hopefully by the end of August. At this point, I expect the pressures to be manageable within our position, particularly given that we are reporting an expected very high level of delivery for our cost improvement programme. And just want to highlight most notably £400,000 expected overperformance in prescribing, and this was a significant area of focus for us over the last year, so it's pleasing to see that yielding some benefits. The ambulance service are currently reporting to be slightly ahead of plan, and I've got a good degree of confidence that they are on track this year. As I previously reported, that confidence reduces as we look ahead into 2025-26. And in order to mitigate this risk, we have jointly commissioned a financial and performance diagnostic to support future sustainability. That work is currently ongoing and on track, and we're planning on presenting it to the Finance Committee and Board in September. Esneft are currently slightly off plan, but still forecasting a break-even position, and pleased to report that this is an improved position from that reported in May. We have been advised that this is largely due to a series of proactive actions taken, so it's positive that this has already had some benefits. Just need to highlight really that that shouldn't be seen as an indication that this is anything other than going to be a very challenging year for that trust, particularly with the implementation of its new electronic patient record, the pressures related to ECOP, in addition to living within challenging financial settlements. West Suffolk is the systems area of largest concern. The Trust are reporting to be some £3 million off plan in June, with a run rate being the rate of expenditure that exceeds income, to have worsened in every month since April. The Trust are reporting that this is largely driven by increased medical costs caused by unbudgeted extra contracted work, and further compounded by a slow identification and implementation of its cost improvement programme, with about half of the 16 million programme either to be identified or moved into a delivery phase. The board should note that unless there is a rapid and significant change, the level of potential deficit is not resolvable within the SNE system, and we therefore have a real risk currently that we might not deliver our approved balanced plan as a system for 2024-25. This carries with it many risks, including reputational, but would also mean that we would not receive £31 million of incentive funding that the NHS had earmarked for us based on planned delivery. West Suffolk have reported to us a range of control measures they have now or are in the process of putting in place, and they have also recently appointed a Director of Financial Recovery. And in order to get back to a balanced plan, the Trust will obviously need to now significantly reduce its overall levels of expenditure. And we've recently received their draft financial recovery plan. We'll be working very closely to support rapid implementation, and we'll also be putting in place an enhanced layer of pay and non-pay authorisation. This is known as double lock within the next couple of weeks. Scrutiny will continue to be via the ICB Finance Committee, as well as via monthly challenge meetings that we are currently having with NHS England. I'll stop there, Chair, and happy to take any questions.
Okay, Howard, thank you very much. Ewan, did you want to respond to Howard's points there at all?
No, I think Howard's laid the position out quite clearly.
Okay, thank you very much. And Chris, from a Finance Committee point of view?
Yeah, I think the report was quite comprehensive, and there are concerns about the West Suffolk situation, and there are actions that have been initiated, and we will see some progress with that. We'll be monitoring the progress.
So urgent actions noted, but in hand. Okay. Any other questions, Moira?
Just to make an offer around the work on CHC, then you, I think we've previously written to ICBs and said we're very happy to work on market shaping with the wider market, given our kind of broader role. So happy to kind of be part of that process and to meet separately about that, if that's helpful.
Okay, noted. Thank you. Any other questions, Ed? Oh, should I go to Janet first and come to you? Are you happy with that, Ed? Yeah, Janet?
Thank you, Chair, and obviously I'm a member of the Finance Committee, so party to the detailed scrutiny that's ongoing. Obviously, it's important to recover this position, but any recovery would potentially then have impact on quality and performance. So I think I just need to have some assurance about how we're going to, ensure that in terms of managing that along with the finance position.
Ewan?
Yeah, so you're absolutely right. There are risks to both quality and performance inherent in recovering the position. Quality obviously isn't a binary thing. We have processes within the organisation to monitor the quality impact of any planned savings schemes. We will work with the ICB on the enhanced double lock to ensure similarly there are controls to haven't identified the entirety of the SIP scheme for the year, so difficult to say that's about things that haven't yet been in place.
Point noted, but work in progress.
Yeah, but there are processes in place to ensure that we don't take unnecessary risks and that they are mitigated where possible.
Yep. Okay. Okay. Thank you, Ed.
Yeah, I think it's just important to keep bringing this back to the patients and the community. I mean, Howard, you talked about reputational risk, the risk of the loss of the incentive payments. But the more we're doing to subsidise a provider, the more we're missing out on incentive payments. It's the community that lose out. We heard about the neurodiversity waiting lists. We want to be pumping money into resolving issues like that. So it's just, this needs sorting. It absolutely needs sorting. And we're 4 months into the year. We need to get a grip of this really quickly, otherwise the year will run away. I know we all know this, but this is absolutely crucial for our community and the sustainability of the system. We need to get a grip of it.
Otherwise a wider population suffer, shall we say. Okay. Noted. Any other questions or points from board colleagues? Otherwise, as well as we know, we'll get a further update in September, as always. Thank you very much. Item 11, performance reports. Paul.
Yeah, thanks, Chair. If that's all right, I'll just kick us off and then open it up to colleagues. I think the first thing to say is I would point you to the SOAC report and just to highlight the fact there's been a slight change in terms of references, in terms of meeting bi-monthly as opposed to monthly. That is essentially in recognition of the fact that committees already mid-monthly did discuss performance on a regular basis, and it felt SOAC needed to be slightly more strategic in its approach in terms of the subject that have been discussed and to give it more time. Just to note that as part of this report. And then central laid out within that is obviously the areas discussed, and at this point SOAC hasn't chosen to escalate anything to the board in terms of board concern at this point. The next area I would point you to is essentially the quarterly performance review, which you will see was a positive review, and regions stopped fairly short of just simply saying we were seen as a highly performing system. And we are waiting for Q1 sort of performance assessment to come through. But if that's coded message that we're doing well, I think it probably is. We're just waiting for the formal education of that. Whether we remain in segment 2, segment 1, who knows? But we're waiting for that to come through. But essentially, quite a positive quarterly performance review. On my part, I would just simply flag a couple of areas. Elective recovery, despite the fact we've had some challenge around industrial action, we pretty much remain on track to delivering at 78 weeks and 65 weeks as we'd planned, which is credit to the hard work that the system's undertaken. But clearly moving into next year, we are waiting for the decisions around 52 weeks and the increased number of sort of outpatient and other elective procedures we will need to carry out as per has been announced by the current government as it currently stands. So it will be a challenge, but we'll be working towards that. In terms of emergency care, just want to flag that we are not alone nationally in terms of not being where we want to be in terms of trajectory, particularly around 78 weeks, 78% performance at the front door. But I received an email yesterday just for noting that there is, as you know, a national assessment where every system are in terms of tiering. Now, tiering is essentially a measure of the level of support the system might require. So level tier 1 being you need a lot of national support, tier 2 you need some regional support, tier 3 you pretty much got plans in place and everybody's happy that we know what we're doing. I'm glad to report we're still in tier 3, which is essentially an assessment that we've got the right plans. We benchmark relatively decently across nationally in terms of that pushing statement, but the hard work continues. And I've recently met with both trusts in terms of stock takes to where we are in terms of forward plans, and thinking about winter, obviously, in terms of the pressures that are going to come through that route. So I'll stop there, Chair. Thank you. I'll be happy to answer any questions with my colleagues. Thank you.
Paul, thank you very much. Any questions for Paul? Elaine?
Thank you. So I just wanted to come back to the part on the performance report around cancer and rapid diagnostics. One of the key issues mentioned is that some services are at risk of collapse, impacting patient care. So I just wondered if you could expand on what's been done to address this and minimise impact on patients.
So I'll check the language of that, because I think that's possibly slightly too dramatic in terms of the situation that we're currently in. I think, though, it's fair to say that within some of our specialties, we're not seeing the level of improvement that we'd hoped for. So within particularly ESNF, we've got significant challenges around colorectal in terms of the waiting time. So we've got a renewed deep dive on that area. I'm going to visit the trust next month. The other area which we have seasonal trend on is skin. So within skin over at West Suffolk, again, we've got particular challenges. And ironically, we've got the situation, we discussed this at the Cancer Committee a couple of weeks ago, where West Suffolk is performing really well on colorectal, but ESNF not, and the converse on skin. So both clinical teams are now going to be meeting to talk about how can they effectively help each other and review the work that's happening within both. But thank you for pointing out, I'll double check the language of that and talk to the team.
Thank you, Elaine. Thank you, Richard. Any other comments? Otherwise, we're asked to receive and note. Duly done. Thank you very much. Board Assurance Framework, item 12, Amanda.
Thank you very much, Chair. So, since the board last reviewed the BAF at the last meeting, no new risks have been identified, no risks have been removed even, and no ratings have changed. However, having said that, we do continue to now improve our BAF and testing and reporting through our relevant committees that report into our board. So by way of example, if we take the RAC risk, strategic risk 31, we have received recently positive reassurances relating to the risk of presence of RAC, and we're likely to recommend going forward that this risk rating is lowered, and the board may consider going forward that we actually remove from the BAF and instead sit it onto the corporate risk register going forward. West Suffolk have been able to provide positive assurances around the work they've undertaken, so that's something that we're going to be taking back through the Estate Committee going forward. The next example I wanted to mention was around risk 8, and that's referring to adult mental health. The Quality Committee have recently discussed, and the entry reflects the work that NSFT have reported to the committee about the improvement in the adult eating disorder service, and the ICB emergency care in SNE, particularly focusing on the corridor care. And as reported previously, we have now improved the scrutiny of all things risk relating, and last Friday we had our inaugural meeting of the Risk and Resilience Group, and that was well received and good attendance from all directorates, and we're looking to meet in terms of next steps in September. So in terms of where we are in terms of BAF, that's currently where we are, Chair, but very happy to take any questions.
Thank you, Amanda. Any questions for Amanda? Or are we... Oh, Elaine, yes.
Thank you. Sorry if I'm raising too many questions. Yeah, one thing I noticed when I looked through it, there's 6 of the risks that there's limited assurance still. So my question was really if there's a target to bring them back into being with the level of assurance that's at least adequate.
I think that's a really good question, Elaine, and that's something that we do, I think, need to give further consideration to with regards to our risk appetite, referring to all of our risks that we report through the BAF.
Okay, noted. Thank you. Andrew?
Thank you. I just noticed, Amanda, the risk between 13 and 16, there's been some sort of formatting glitch and there's bits of information missing. I wonder if that might be something that could be circulated to the board after the meeting, just for information.
Yeah, agreed. And yeah, thank you, Amanda. Ewan?
Yeah, just on the RAC BAF risk. I mean, given the discussion we had earlier about the national review, and yeah, you're absolutely right. The controls in place are robust, but it does take a significant time to build a hospital, and any delays to the national programme, I think, would rapidly re-escalate this onto the BAF. So I would suggest that we keep it on for now.
Constant review.
Yeah.
Yeah. Yeah.
I mean, the controls of risk shouldn't necessarily determine whether it's on the BAF. The risk to the strategic functioning of the organisation is the thing that should determine it, really.
Good point. Yeah. So with those comments, are we happy to receive, note and indeed approve as recommended? Agreed? Lovely, thank you very much. Item 13, ICP update. Sharon.
Thank you. I'll try and be quick. So just to summarise the last meeting and the next meeting, really. The last meeting we held, the ICP committee was the 14th of June. That was during the pre-election period. So we were a bit limited as to the subjects we could discuss, but it was still quite a full agenda. We had a presentation around Beat the Street initiative in Ipswich and Harwich, which aims to promote physical activity in individuals, families and communities. There's quite a lot of data that it generated around populations and what works. So that was shared, and there was an inspiring kind of discussion on how we could build on that approach to learn more and to use data in imaginative ways. The digital team, transformation team, gave us an update on digital transformation around things like digital shared care records, enabling patients and carers to access records, ensuring comprehensive patient information to support personalised care, planning and delivery, also using PHM, population health management, to support that as well, and the importance of timely and accurate reporting and recording as well. And we had a discussion around co-production. Sue Conker, who is working at Healthwatch Suffolk and the Integrated Care Academy, is also a PhD student who shared her current research around developing a novel framework for not just traditional co-production, but also co-delivery, a new model for involving people in co-delivery, which I think has got some real interest in the system. The next meeting is going to be on the 9th of August. We're going to have an update on air quality, which I know is always an interesting topic. And I think that's also going to go to Health and Wellbeing Board in Suffolk at some point, but there's an update to us initially. But that will reflect Suffolk and Essex rather. We're going to discuss system assurance and links with the CQC as part of their developing their frameworks for assessing ICSs. They want to build relationships by attending some of our meetings. So we are inviting them to some of our ICP meetings, and in order that they can understand the way that our health and care system works, the same with other ICSs as well. So there's a paper that proposes the framework and approach for that will be jointly presented by CQC and Susanna. We are going to look at the people communities refresh, so there's a draft terms of reference, and we're also going to revisit the Uncomfortable Truths events, which many of those present here today have attended those meetings. They were really valuable events that we held to understand the how, why and what of systemic inequalities that people experience. We've raised high expectations in our system that we can do things differently, and we've actually come up with 22 things that we can do, some potential actions, because we wanted something concrete to come out of that. So we'll be presenting that and asking partners, inviting them to self-assess their progress against those actions. Lots of people have started those actions, but we want to push organisations, partners to move further. And there will be support of the People and Communities Committee and the ICP Secretariat to enable that to happen. The only other thing I wanted to highlight was that there is a continuing programme of events around Future Shift and listening to people, partners around the system on that through the summer, and in September we'll have another meeting coming together on that 25th.
Yeah, 25th, did you say?
Yeah.
25th, yeah. Good. Is that you done, Sharon?
That's me
Thank
done.
you.
Thank you.
Lovely, thank you. Any questions for Sharon? Received and noted. Thank you very much, and thank you for all the great work. Item 14, ICB self-assessment. Amanda.
Thank you very much, Chair. So April 23, all ICBs across the country were invited to undertake a self-assessment. And we indeed took up the mantle, and we have been working over the last 12 months on self-assessing our current performance as a board and identifying areas for potential further improvement going forward. Opinion amongst board members, as we probably would expect, and we may wish to consider as a board how we want to take forward those suggestions and areas of improvement, perhaps in a future board development session, perhaps looking into the autumn. So picking up some of the comments that we received around simplifying our governance structures and processes and helping improve the flow of information between the board and indeed its subcommittees. Last week there was a conversation between the executive team and the chair to consider that very issue, and as a result of that conversation we have agreed to initiate a review of the ICB's current governance processes, which will hopefully reflect back the feedback that we've given through the board assessment, and I think we could potentially look to unravel and develop going forward potentially in the autumn. So that's really all I wanted to say, Chair, but very happy to pick up any questions.
Thank you, Amanda. So questions for Amanda? Otherwise, is a fair summary to say wide responses to the questions as returned. Clearly, we're in the storming, forming, norming process. We're hopefully now heading to the forming, for which we know there are further actions to be taken, and the suggestion is that we follow the points raised and the issues raised in the feedback through a future development session, review of governance, and back to board. I suspect, is that a September or a November issue, do you think, Amanda?
I'm thinking, probably given the amount of work to be done, I'm thinking November.
Especially if we can get a development in before,
Absolutely.
if we can.
Yes.
So over to the scheduling team. Everybody content with that way forward? Lovely, thank you. And Amanda, I think you're on a bit of a roll here because you're also going to take us through the leadership competency paper.
Brilliant. Thank you very much, Chair. So this paper has been previously discussed through the Remuneration Committee and indeed at an earlier board seminar earlier on this year. We are still awaiting the leadership competency framework, and we are expecting that to be issued this autumn. In terms of the recommendations previously presented, some of the deadlines have actually passed. For example, we have been required to complete the process around the fit and proper person test, and indeed our return was submitted to Region a few weeks ago, and indeed the process in terms of appraisal for the chair has been concluded at the end of June. The only piece of work that we still need to conclude is the PDP process for our NEMS, and that process needs to be concluded by the end of this September. And then following that paper, we have recently, well in the last few days actually, received notification from NHS England that they have now announced changes to all ICB constitutions to indeed allow the appointment of a deputy chair and a senior independent director. And what we plan to do is, through the Remuneration Committee and subsequently board, bring a paper back detailing how we'll be making those two appointments. Thank you.
Okay, everybody content with that? Received and noted. Lovely, thank you, Amanda. In which case, committee minutes and highlight reports. I know your name's against this, Amanda, but I wonder if there's anything you'd like to say, or should we just go straight for questions?
I think we go straight to questions, and maybe the chairs of the relevant committees bring to our attention anything by way of exception.
And I'll ask that as an open question. So if you are a chair of committee referenced in this paper, if there's anything you would like to raise, now is your opportunity. No hands raised. And any questions on any of the minutes and reports presented there? If there are none, received and noted. Agreed. Lovely. Thank you very much. Attendance log, I'll do the same. Any questions? It's there for board members to look at. Otherwise, received and noted. all done. And before I go to questions from the public, any other business? So none raised with me. Does anybody have any other business they'd like to raise? I'm just looking around the table and I don't see any hands raised. In which case, let's go then to questions from the public. I'm going to start off with Simon. You're going to read out Mr. Dooley's third question.
Question, which is, would the board like to respond to the change of phrase from the NHS service being free at the point of need to free at the point of service?
Okay, and who is answering that one? Am I coming to you for that one, Ed? Thank you.
My only response is that with the NHS constitution, which sets out the exact constitutional wording of the health service, the first two principles are that the NHS provides a comprehensive service available to all. And secondly, access to NHS services is based on clinical need, not an individual's ability to pay. So that I don't think we've departed from that in the NHS constitution.
Okay, thank you. And any other questions from members of the public? So I've got two hands raised. Shall I go to you first, Mr. Dooley? Well, I don't mind which I go to first, really, but who wants the microphone? Anyway, if you introduce yourself and over to you.
Thank you. My name is Mrs. Barbara Robinson. I'm representing the voluntary sector and a group that has existed since the late 1990s, Suffolk Youth and Parent Support Group. I'm also a member of a Task and Finish group which hoped to see delivery today. It's been delayed till September for a specific specialist service, ME services. I'm here to ask a question on behalf of a local family who have been members of our group for 25 years or more. Sadly, I received the news yesterday that one of the family members had been admitted to Woodlands having attempted suicide because of his extreme health needs, complexity, comorbidities. They have asked that his voice is heard today, and the carers, the family, want their voice heard. They are willing to go public. I have directed them to inform Health Watch, and they are being supported by Suffolk Family Carers, who will coordinate, if you approve or think it's a good idea, to offer this as a case study for the work we're doing under the Task and Finish group. The acting manager at the minute for this is Claire Corbett, and she said, we need human touch, we need the lived experience. This is a very unusual of obsessive compulsive disorder, all of which are labelled, and he has been totally failed in his support and his life pathway by the essentially social care shortfalls locally. And this has led to him, after many years of difficulty, of trying to take his life. This case study is what has been suggested to us, and I'd like your opinion on it. They have gone public before, so if you were minded to think this would be a good idea and it would help the family and expose, this will help learn, inform and improve. And we have within our grasp a really excellent programme specification and pathway which might assist in these really complex cases. The voluntary sector have discharged because he's too complex. He's too hot to handle, he's too complex to handle. So where does he go? Thank you.
Thank you, Barbara, for that. Richard.
So thank you, Barbara. Really awful, and Claire did mention that to me a couple of days ago. So firstly, yes, I really want to hear more about that specific case. I was thinking if Lisa and I maybe pick that up offline with you. We're going to a break later, so we'll try and pick up with you then on the specific case. I think it is helpful to have some of these case studies to bring to life the particular business case that we're bringing through to the board in September around the ME and CFS and long COVID-based service provision. But I'd like to just talk to you a bit more about the specific case, if that's okay, and is there anything we can do more immediately to support the person that you've talked to. And Kath, I saw noting down clearly at the moment the person's in Woodland, so I'm sure between us we can start to specifically look into the case. So yeah, I'm happy to pick up with you offline, Barbara.
Yeah, thank you, Richard. And I think I also saw nods from Kath and Georgia and Lisa. So sounds like an action immediately after this this meeting, and we'll pick that up appropriately and take it forward. Thank you very much. And Mr. Dooley.
Yeah, well, first of all, could I say that I'm more than disappointed at the responses to the previous 3 questions. I feel like I'm in that Ronnie Corbett sketch where you get an answer to a question that you didn't actually ask. And whilst that might be amusing on the telly, it's not amusing for me in this room. William, I really appreciate the fact that you've referred back one of the answers from the previous meeting, and I think you're going to have to do the same for the first 3 questions that are asked today. Totally unsatisfactory in my view. Let me have a go at this one. It was reported in the press, and I assume everybody is aware of it, that a newborn has been left disabled after signs of serious illness were missed by a physician associate. That's at West Suffolk Hospital. That's obviously tragic for the parents and obviously the child, but also it raises questions about workforce. I've asked previously about whether the maternity provision, midwives, whether they're adequate. I was on a picket line of the junior doctors where I was told that on one night in the Ipswich Hospital, they were short of 8 midwives. That's totally unacceptable and unsafe. We're now getting these PAs appointed who aren't qualified. That has literally led to deaths of people, and in this case, disability. What is the board's response to this horrendous situation here in our patch, but also more generally around the country? I'm aware that PAs have been appointed a few back 20 years, I'm told. So why is it that there's a consultation going out at the present time asking for views in terms of how these people should be regulated and so on and so forth? There was 20 years to do this. We've got these people appointed to these posts at the present time, and they're failing. Their failure means death and injury to patients. Please respond intelligently.
Okay, thank you, Mr. Dooley. Lisa.
Thank you. I'll just pick up on your question about the midwifery workforce, Mr. Dooley. Thank you for your constant concern about the midwives. So the data that I have, the May workforce data, so at West Suffolk there's 126.53 midwives in post and 4.82 vacancy. There is 0.7 whole-time vacancy at Colchester and 131.19 whole-time equivalents in post, and no vacancies at Ipswich and 139.8 whole-time equivalents in post. So the midwifery workforce is in a better place than it's ever been across Suffolk and North East Essex. I appreciate, and I would too have concerns about the 8 people that were not on shift. When you look at maternity staffing, however, that probably wasn't just one unit. I wasn't there to hear what you heard, but it would have been across the whole maternity unit, so the antenatal, postnatal wards and the labour delivery suite as well. I visited West Suffolk last week. I went to their maternity unit, their neonatal unit. I'm visiting Ipswich and Colchester again soon. I'm very assured that they have good oversight of their workforce arrangements, and I would hope that you would also be assured There has also, in addition to that, been an NHS England visit. We do 60 steps to safety. NHS England and the ICB join the trusts, and we look at all the safety critical issues. Workforce is one of them, and there's been no concerns around workforce raised. So there will undoubtedly be times where workforce numbers are down, but I'm assured that the actions and the mitigations that the trusts have in place to resolve those issues are there. Thank you.
Okay, thank you, Lisa. Andrew?
Yeah, so I'll take on part of the response about physicians' associates. As you know, and I'm not going to teach you to suck eggs, physicians' associates are part of the NHS England long-term workforce plan, and obviously as part of the NHS we'll work with NHS England in implementing that. I'm committed though to making sure that physicians' associates are both employed but also deployed safely. Harm has been caused to our child as a result of the circumstances you describe. So I propose that I respond in writing to that part rather than potentially not doing the answer justice here.
Okay, thank you. If there are no more...
Another question.
Oh, have you? Go on then.
Thanks, Lisa, and sorry for not being able to, you know, that was a serious attempt to answer.
Just put your microphone a bit closer.
Sorry, so 1 out of 4 is not good, but not bad. How about this one? You'll be aware that Unison members in Colchester Hospital, part of ESENFT, whatever it's called, have balloted for strike action, having been provoked into doing so by the proposal to outsource their services to the private sector. What's your view on this provocation? Bearing in mind that we started the meeting with a reference to GPs taking action, presumably. Surely this isn't the situation that we want. We want the service to continue without disruption. Do you agree?
Thank you. And Ed?
Thank you, Anthony. We'll get a written answer to that. Obviously, if Nick was here, he'd be well placed, much better placed to give a view, but we'll take that away and send you an answer.
My final question is in relation, as I understand it, NSFT are being instructed to save, in inverted commas, £17 million. How is that meant to enhance the prospect of decent services for the worst performing mental health trust in the country?
Okay, go on then, Kath.
Thank you so much for your question. So every NHS trust in the country has an efficiency target. NSFTs equates to approximately 5%. So that's about average in relation to many organisations across the country. And our approach to this is not to go down a traditional cost improvement programme approach, which gives the impression that it's all about just saving money. We have an efficiency, value and innovation approach to our cost saving. Because it's not just about the money, it's about how we use our money much more wisely. So I'll give a simple example. One of our EVI programmes is to eliminate the use of agency workers within the Band 3 clinical support worker workforce. We should be recruiting and retaining our own staff and having the right establishment to ensure that we have the capacity within our teams in order to be able to deal with surges of demand, and of course using bank staff as opposed to agency. That is an efficiency, value and innovation programme which saves money and improves outcomes for service users and for staff as well. So it is really a big focus on improving quality and using our money much more wisely so that we don't waste money and that we spend everything that we have for the best outcomes for our service users. Thank you.
Kath, thank you very much. And with that, we are scheduled to finish at 11. It's 11:01. We therefore will close this meeting, and the next meeting is on the 24th of September, so I look forward to seeing you all there. And we've got a 15-minute break now. Stretch your legs, get a cup of coffee, and then we go into the part 2 of our meeting. So thanks very much, everybody, and see you in September. Okay, thank you.